even though CT surgeons do more than just heart surgery, this lecture is going to focus on identifying the murmurs and knowing how to treat them. We're going to go after the major four: mitral stenosis and regurgitation, aortic stenosis and regurgitation. We're not going to touch the other ones, and we'll wrap it up with coronary artery disease. The important thing here is for you to be able to move the button around on the picture, on the little guy and the test, and listen for the murmur, knowing where the murmur is heard and what it sounds like, being able to use that to identify the murmur and back it up with the story in the vignette. The two go together, probably have the answer right. So let's start off with systolic murmurs first. And the first one we're going to talk about is aortic stenosis. Aortic stenosis is a problem of calcifications. This is essentially atherosclerosis, and who gets that but old men with CAD. So old men with CAD are likely to present with chest pain. So that's the most common presentation of aortic stenosis, is chest pain, but you might also have syncope if the valve is really bad, or full-on CHF. CHF carries the absolute worst prognosis. The murmur of aortic stenosis is heard best in the second intercostal space, right sternal border. It is a crescendo-decrescendo murmur in systole that radiates to the carotids. You diagnose aortic stenosis with an echocardiogram, as often you will do for each of these valvular disorders, and the treatment is replacement. And this is important. You are not able to perform a balloon valvotomy on aortic stenosis. That's because it's from calcification and the balloon does nothing. Bicuspid valves accelerate the process of calcification, so it'll get worse earlier. But I want you to be aware that there is an endovascular repair for aortic stenosis, TAVI and TAVR. It used to be that open heart surgery replaced the valve as the only thing you could do, and the balloon was used for palliation only because it probably wasn't going to work. Now you can have a complete endovascular repair of the aorta without cracking the chest, making those non-surgical candidates for open heart surgery have an option to replace their valve. Still, for the test, aortic valve replacement, balloon valvotomy only for palliation. The other systolic murmur is mitral regurg. And mitral regurg is caused by infection, like endocarditis, or infarction. And by infarction, it's going to be one of two things. Either the papillary muscle ruptures or the chordae tendineae ruptures. Why that becomes an issue, I don't know, but the test sometimes asks prevalence stuff. Papillary muscle, far more common than chordae tendineae rupture. Mitral regurg is a systolic murmur heard best at the cardiac apex. It radiates to the axilla and is holosystolic. Holosystolic means covers up both S1 and S2. Diagnosis is echocardiogram, and the treatment, replacement. All right, that's the systolic murmurs. Let's talk about the diastolic murmurs. The first being aortic regurg. Aortic regurg is also caused by infection like endocarditis, infarction, or dissection. An aortic dissection that returns proximally can get into the aortic valve and lead to aortic valve regurg. Now, usually aortic regurg is going to present with acute presentation. This is devastating. The person's going to be in florid heart failure, cardiogenic shock. They're going to die. However, they can also be chronic, but is more insidious. In this case, you hear the murmur and that tips you off. The murmur of aortic regurg is diastolic, heard best at the fourth intercostal space, left sternal border, which breaks the whole aortic valve heard at the aortic valve place. It's going to be diastolic, decrescendo, and described as blowing. The diagnosis, confirmed by an echocardiogram, and the treatment is to replace the valve. But when you do this, you have to give consideration for cabbage. That is to say, the ostia of the coronary vessels are in the valves of the aortic valve. And so if you have regurgitation, you may have compromised coronary blood flow. And if you do, and you're cracking the chest anyway, you might as well get in there and fix that too. The other diastolic murmur is mitral stenosis. Mitral stenosis was almost exclusively caused by rheumatic heart disease. And since we treat pharyngitis with penicillin, you're not going to see this a whole lot more. But the murmur is very classic, and so the test still likes to go after it, not because rheumatic fever is so common, but because it's an easy murmur to identify. It is going to be heard during diastole at the cardiac apex. It is a rumbling murmur with an opening snap. And the opening snap is going to occur earlier in the murmur, the worse the murmur is. And because it causes blood not to be able to enter the ventricle, the left atrium may dilate and you may present with CHF or AFib. Diagnosis is made by echo. And the treatment can start off first with medical therapy, so you don't have to intervene until you absolutely have to. You're always going to intervene before CHF sets in. So treat medically. The mitral valve is not calcified, so you can do balloon valvotomy, and eventually it may need to be replaced. The reason why this is so important is because rheumatic fever, rheumatic heart disease, is going to occur in someone who's young. And so if you go in and replace the valve early, replacement valves are only good for so long. So you may have to go in the chest again. And the common teaching is you can only go in the chest 3 times. So ideally, you'll use endovascular techniques to stave off needing the replacement. But when someone has a replacement valve, there's 2 things to consider. Is it bovine? That is it organic? Or is it mechanical? Organic valves don't last that long, less than 10 years. But they need no anticoagulation. Mechanical valves are good for 10 to 20 years, but do need anticoagulation. Usually you use warfarin and target an INR higher than what you'd think, 2.5 to 3.5. More so than someone who's had a DVT-PE. These are the considerations for valvular disease. Let's finish it off with coronary artery disease. We have a whole lecture on this in medicine. The pathology comes from the risk factors of coronary artery disease. And this is going to be the fat, hypertensive diabetic who smokes cigarettes and has bad cholesterol. Age is also a risk factor. For women, it's over 55. For men, it's over 45. The patient who's got chest pain right now is likely to be coronary if it meets these 3 criteria. The first is substernal chest pain. The second is a worsening of the pain with exercise. And the third is improved pain with nitroglycerin or rest. The more of these things you have, the more likely it is to be coronary artery disease. The less of you have, the less likely it is. The diagnosis is going to be made first in evaluating someone with chest pain with an EKG. If you see ST segment elevations, they have a STEMI, they go to cath emergently. If the EKG is normal, but the troponins are elevated, they have an NSTEMI, and they need to go to the cath lab urgently, but not emergently. And if you still think this chest pain is coronary in nature and the EKGs and the troponins are unchanged, you get a stress test. And if that's positive, they've got symptomatic coronary artery disease. And all of these end up with a left heart cath. The left heart cath is going to tell us is either it's only got 1 or 2 vessels and they're not that bad. This person gets a stent. Don't forget clopidogrel. If, on the other hand, it's 3 or more vessels, or there's a left main stem equivalent. And a left main stem equivalent is going to be the left main is actually taken down, or there's a substantial portion of the left anterior descending and the left circ. Big vessels that matter a lot should not be stented. Small vessels far out in the periphery, just a few of them, they get stented. Everybody else, big vessels or lots of vessels, gets a cabbage. Now, obviously more goes into this than just this decision, but what I want you to see, 3 or more vessels or the left anterior descending involved, cabbage. Only 1 or 2 vessels, small peripheral, can stent them. This is where CT surgery comes in, on the cabbage. The way this works is that you're going to crack their chest open and you're going to use the left internal mammary artery, the lima, and you tether that to the most important artery. So in the case where you had an LAD lesion, you would bypass the lesion of the LAD with the left internal mammary. Every other vessel is going to be grafted using a saphenous vein graft. You take the saphenous vein out of their leg, chop it up, and bypass all the other blockages that you can find. When the person comes out of surgery, they're going to be placed in all the coronary artery disease medicines. They're going to be on a beta blocker, aspirin, ACE inhibitor, and statin. And the management immediately post-op is based on antiarrhythmic management, getting the tubes and drains out when they stop draining, and avoiding exertion. You don't want them to use their chest muscles, otherwise they might tear their sternotomy. As they leave the hospital, it's about cardiac rehab and maintenance of their risk factors. Control these to prevent recurrence of coronary artery disease. So we talked about 4 different valvular disorders you have to be able to recognize for the test, knowing that almost all of them are going to result in surgery. And then you have to decide, is it organic? Generally not, unless they're not going to live very long because of the convenience of no anticoagulation needed, but doesn't last very long. Or mechanical, they are going to live a long time, and you need to anticoagulate them to an INR of 2.5 to 3.5. And then we covered coronary artery disease, where you really need to make the decision of left main stem or lots of vessels, get a cabbage, very small vessels, and only 1 or 2 of them get stent plus clopidogrel. That's CT surgery. Become a better doctor. Subscribe now to get access to our premium content.